So, respected chairpersons and moderator, my dear teachers and learned audience, my topic is embolized material retrieval when and how. So, device that might be embolized may be stent, maybe guide rod, balloon, maybe the guide catheter tip or part of the segment of the guide catheter. Short wire from the femoral or radial sheath, that may be the device used for congenital heart disease. So, stent loss, multiple factors are related to the stent loss. That may be patient factor related to the operator spectral lesion and the procedure factor as well. Mostly the contributing factors are more than 2 or at least 2. More commonly, the stent that is lost or embolized, coronary tortuosity, angulation, fibrocalcification, CTO lesion when it is not well prepared, as well as forceful manipulation, pull, push, or rotation, especially against the resistance that the previous speaker, Dr. Orun, was telling. Anything against resistance is an important factor that might produce the stent loss either in the coronary or partly in the coronary and partly in the aorta. So there might be several scenarios in stent loss. That may be the partially lost. That means balloon is, especially when forcefully pushed, stent is behind, balloon goes beyond the stent, and sometimes when stent is not going to the up to the lesion, we used to pull back the balloon and the stent back. At that time, that balloon may be lost from the stent. And others, in these circumstances, the one way is to remove the stent as well as balloon by after a small inflation 2 to 3 millimeter, and all the things can be pull it back. This is the total stent loss where the stent balloon is totally lost, only the wire is either inside. In that circumstances, we can reposition the stent by putting a smaller 1.5 millimeter balloon proximal to the stent and then pushing it distally, or the same balloon like 1.25 millimeter balloon or 1.5 millimeter balloon, a smaller balloon like 6 or 8 millimeter length, pushing distally beyond the stent, then inflation at 3 to 4 millimeter atmosphere, then pull back to retrieve the stent. Other way, the stent may be lost totally. There is nothing inside the stent. Wire is lost also, but still the stent is in the coronary artery. In that circumstances, more easier way is to crush the stent, but initially that should be done by a balloon followed by the another stent inflation. And sometimes stent may be lost in the aorta or periphery. So these are the stent retrieval devices. More commonly we used either gooseneck snare or N snare, and sometimes we use, that is the handmade innovative snare. That is a very important tool. So these are the method by which the stent can be retrieved from inside the coronary artery. First one is the balloon inflation technique. Second is the retrieval by that of snare, that is micro snare, and that is a very delicate and should not be tried because that may produce some injury to the parent vessel. And other way that snare multiple wire twisting is the another method, but that should be done by a very skilled operator only. Otherwise, whole thing may be produce thrombosis that may be difficult to make it out, and whole system may be either slow flow, no reflow, or there may be a lot of injury to the vessel. So my first case is transradial, that was stent. LCX was totally occluded. That was there was lesion in the LED that was dealt with first. Then LCX was crossed. There was a long lesion, fibrotic lesion, as well as lot of dissection. That was the transradial procedure, 5 French catheter. So that is the drawback here. So long stent, 38 millimeter stent was there. Initially it was not crossed the lesion. So again pre-dilatation was done and further tied with the same stent. At this time you see there is a lot of handling of the stent and catheter. You see the stent is across the tip of the catheter. Catheter is manipulated in a very bad way, and at some times the balloon is pulled back posteriorly, that is away from the stent, in that stent, and stent is edge is distal. So in these circumstances, whole things was pulled back. So this is the area that should be very much careful, because anyway any substance, foreign body, if it is dislodged in the arch of the aorta, and if it goes in the carotid or vertebral artery, that will be disastrous. So it is better to pull the foreign materials, anything from the aorta, up to the radial artery where it is quite safe, or up to the iliac artery where it is quite safe. So after coming to up to the radial artery, it was removed by multi-wire twisting method. So second case is the floating stent in the aorta and RCA ostium. That was a calcified lesion. Stent was lost, and partly that was floating into the aorta, and partly it was strangled with the ostium of the RCA. So by snaring it was removed. So this is the stent after removal that was totally deformed. So my third case is from the left main. That was actually the left main PCI 6 months back was done. Patient presented with effort angina class 3. There was a critical lesion of the LCX, and that was pre-dilated, but during stent placement, the alignment of the catheter was not good. So stent was stuck with the previously implanted left main stent. So it was difficult to, so ultimately it was lost from the catheter, it was lost from the wire, it was lost from the balloon. So ultimately it was removed by snaring. So this is the handmade snare that can be made easily in the cath lab, and I think everybody should know about the procedure, how it is made. So fourth stent is lost in the LCX, and that was innovatively managed. So stent was lost here. Stent was lost here. When I tried to pull back the stent was here, but the balloon came out. So stent is floating here over the wire. So what I did, I put a second wire outside the stent, and with a new balloon pre-dilate the lesion very vigorously. After pre-dilatation, I took another balloon over the wire that was with the stent, and that is inflated at 4-5 atmosphere, and that was pushed, and other balloon that was used for pre-dilatation was back. That is some kind of ping pong method. And this way the stent was placed in the lesion, and it was inflated, and ultimately with the same stent. So take home message, device embolization is infrequent but might be sometimes catastrophic. Adequate anticoagulation must be maintained throughout the procedure. Guide catheter alignment, not to push or pull any device against any resistance. Definitely left main coronary retrieval technique is better than to crash it there. And there might be difficulty, most difficult is the LCX to retrieve, and multi-wire technique and recrossing technique should not recommended because with low success rate, and lot of complication may be inside the coronary artery. Biotome technique should be discouraged, and definitively anything if it is lost and if it is not found fluoroscopically, the special attention should be taken whether it is lost in the neck or in the brain area by either CT scan or by MRI. With this, I like to thanks for patient hearing.
Thank you, sir, for your excellent presentation. So any question from our panelists? Any questions, sir?
Most important is one should know all these techniques of retrieval when there is a stent loss, but more important is that what should not be done so that this situation doesn't arise. That should be learned, because it should be a very rarest of rare events. So basically, the basics of intervention, like pushing anything or pulling anything when you're feeling that something is trapped, should be preempted, and the bed should be adequately prepared. Calcified lesion should be adequately treated, and sometimes this ox hardwares that we use, they also are not the right ones. So if you have a difficult case, you should go preempting that this event should not happen.
Yes, that is very important. But actually, I like to just take some opinion from the senior Shet sir and Supya madam and all others are here. Dr. Arun is also here. This is there is temptation that a small push, a small pull may complete the procedure like this. How many, I think, try to avoid this temptation? Sir, my coach, he was telling that don't push or don't pull anything inside the coronary or inside the any artery against resistance. So I think even all senior and expert on, always we try to do the pushing or pulling because of temptation. That's a small pull, a small push may complete the procedure like this.
So small pull and push, I think Dr. Seth will be telling.
So small actually that usually after a few seconds it becomes moderately push or moderately pull like this. Yeah, this is I think this is my temptation. I don't know how the seniors are.
How do you know how much to push?
Oh, on what?
Like to prevent embolization, to prevent the
embolized material. Actually, if you push too much, what will happen?
You don't want to push too hard. You don't
Yes, Dr. Pratap, you can just.
Pushing what?
Actually, we were in some discussion, sorry.
So, no, yeah, I mean, no, first of all, that's always a very hard question to answer, right? How much to push or how much to pull.
Yes,
but in
exactly.
general,
I
would completely agree with what Dr. Vijay Kumar said. You know, when you're pushing too much, and that comes with experience, and sometimes experience comes with bad, one or two experiences, right? So how much to push? If your guide is backing out, etc., walk away when you can. So, like for example, like in the case that you showed with the radial, where you had 5 French ear dissections, it was circ, right radial. I mean, could we have prepared the bed a little bit better? Might have averted it. So, it's one of those things with CTOs. I mean, you saw that there was going to be a challenge, right? So, going back to even what Dr. Seth was saying during the last talk, like for a right, for example, Amplats 1, because you want backup. And he said the only time he uses it is for CTOs. So in general, our philosophy again is like, I think even the Japanese operators, Pratap, all of us, we go with at least 7 French guides, I think, for the most part, when we're dealing with complex work, just because it makes life a little bit easier. I think sometimes those preventative stuff really helps. Preparing the bed helps. If you're dealing with calcium tortuosity, sometimes it's... I don't either.
I don't use 6 fingers.
So if you have a good supporting guide, if you have made the bed adequately prepared, and suppose you have taken a 48 millimeter stent and your artery is very tortuous, and you have a 6 French guide and you start pushing it or pulling it, that's the time when you end up having these mishaps. Or if you have chosen a wrong wire for a side branch and you have gone up high pressure in a calcified anatomy. So you should know that there is a calcification at the bifurcation and your wire is there. If you go 20 atmospheres to across that wire, then that wire will get trapped. So all these things have to be preempted and all the precautions taken so that support is good there, good support is there, and you don't push and pull the things.
I think the good visualization like IVAS and OCT is also important in these cases, and body wire technique may help. For pushing the catheters, body wire technique, and
body
also,
wire technique.
Yes, and IVAS and OCT also helps in these cases.
Ashok. Ashok.
Yes, sir.
I'm trying to, the first point was this, the situation shouldn't happen first. How to stop the temptation? To stop temptation, the first thing is to make certain justice to the whole issue. First justice is to yourself, how much you are trained for this thing, which I think you are already there. Second justice to the patient, whether this patient has the capability or not, doing it or not. Third justice is the technological justice, whether this technology is correct or wrong. And fourth justice is that whether you'll come out successfully or not. So the point is, the whole issue shouldn't have happened.
Yes.
And the temptation is an issue that is born out of injustice to the whole system.
Yes.
I hope you can maintain this justice for the future. And this is not the way to make the people's therapy put into jeopardy, and then we discuss it in the way this which it may happen. Thank you very much.
Thank you, sir.
Ashok was asking because we did, as a senior, a lot of cases, whether we faced it or not. This is true, but we have also learned from our mistake, but that's why we can tell you again and again. The thing is that when you're doing it, as I always say, make sure their guide is sitting nicely and is not going to pop up every time you do something. Then you're aware. If it goes nicely, then you know that, and always keep an eye on the tip of the wire where it has gone. And next you are dealing with the balloon. Then if you're dilating it, then when you're handling the balloon, we can feel it. When that it is roughly coming, is stuck somewhere, even in very finest way, you can feel it if you do it slowly. This thing happens usually when you're at the end of the day doing a lot of cases and your brain is not that much fresh, or sometimes you're trying to rush off for something. But the name of the game is that you need the landing zone, the bed properly, the proper way that you can land there with a stand. So that if you give time before, then after complication, then it's always better. So you give time and make sure that your bed is nicely prepared for landing. And sometimes there is a manufactural problem. It used to be in the initial stage. I mean, Ashok will also agree, balloon, and we used to crimp the stand. All these things are gone. Now it's much better, apparatus are there, better balloon, better technology. But at the end of the day, you must make sure what you have done, where your landing zone should be nice and prepared. If you are okay with that, any time when you are passing this stent, if you find any resistance, you shouldn't try. This is number one lesson. You shouldn't, because whatever you do, there is a chance of getting stuck. You may be lucky to go through either body wire or whatever, but if you are stuck, please don't try to push it, and try to put it there to finish your work. Only the top, the Allah or God or whoever is on the top is watching you. Nobody else is watching. That's why you're doing. So whenever you pass any stent, any resistance, see why that part is resistant. So if needed, you take time and dilate that thing, that part, and do it again. That is better. Nowadays you have got the IVAS, but we didn't have those. So you used to feel and then do it. So most of the time, if it goes smoothly, then but if there is any single resistance, try to find out why this resistance is. Yeah. Then this thing can be avoided.
Thank you.
Thank you.
Thank you,
sir.